am Dr. Kumar Agarwal, Senior Medicine Consultant, Maradi Hospital, Adgaon, Guwahati. I would like to talk regarding ARB usage in COVID-19. To date, the 2019 novel coronavirus outbreak is being a major concern of the scientific community to treat the potential medications. Following a rapid increase in the cases of COVID-19, different observational studies are undertaken to identify the possible risk factors for infection and related core outcomes. 17% diabetic cases were reported among 52 critically ill patients with COVID-19, and 16.2% diabetes mellitus and 23.7% hypertension cases were identified from 1,099 patients by Guan et al. Similarly, out of 140 hospitalized patients, 12% diabetes mellitus cases and 30% hypertension cases were observed in critically ill patients with COVID-19. Hypertension was independently associated with the severity of COVID-19 on admission. Hypertension is a risk factor for aggravation of the disease in COVID-19 patients. The large percentage of patients with hypertension undertaking ACs and ARBs was a remarkable characteristic among those presenting severe COVID-19 manifestations. These are classes of antihypertensive massively used as first-line therapy due to their additional kidney and cardiological protection that occur regardless of their use for blood pressure control. ACE2 is established as a functional receptor for the entry of SARS-CoV-2 into cells. SARS-CoV-2 enters the host epithelial cells after the spike protein's receptor binding domain binds to the membrane-bound ACE2 receptor. ACE2 is a type 1 integral membrane glycoprotein. The highest expression of ACE2 is observed in the kidney, the endothelium, the lungs, and in the heart. The probable rationale proposed for the possible relation between the use of ACVs, ARBs, and progression to ARDS in COVID-19 is the increased availability of ACE2 attached to surface of the lung endothelium, and inherent effect of these two classes leading to enhanced coupling of SARS-CoV-2 to ACE2 and its consequent cell entry. Receptor binding domain of SARS-CoV-2 has a stronger interaction with ACE2, and any increase in ACE2 expression may potentially amplify the virus capacity to enter the cells. Distinctly, ARBs increase angiotensin II availability since this class blocks its coupling with AT2 receptor, leading to compensatory upregulation of ACE2 in the membrane. Cellular entry is followed by endocytosis and further viral replication and subsequent release. SARS-CoV-2, after entry inside the cell, causes downregulation of further ACE2 expression. ACE2 is responsible for the conversion of angiotensin II to angiotensin to inactivate angiotensin 1 to 9. Downregulation of ACE2 results in an unopposed action of angiotensin II through its AT1 receptor. ARB oppose angiotensin II's action by blocking its synthesis and receptor. ARB may also cause overexpression of the soluble form of ACE2, which intercepts the binding of SARS-CoV-2 with membrane-bound ACE2, thus inhibiting the viral entry into the host cell. The new data published in JAMA Network Open show that after adjusting the multiple variable, COVID-19 patients treated with ACE2 inhibitors and ARBs had a significantly lower risk of death and severe adverse events, which includes the need for intubation, mechanical ventilation, or admission to ICU. When compared with those not receiving the RAS inhibitors, BRACE Corona trial, which was presented at the ESC Congress, showed that hospitalized patients with COVID-19 who continued on their previously prescribed ACE inhibitors and ARBs were not at an increased risk of dying or remaining in the hospital when compared to patients who stopped the medication. The Replace COVID trial, which was published, came to a similar conclusion. Abrupt discontinuation of therapy puts them at risk of complications, rebound exacerbations of the disease. In patients with hypertension, discontinuation switching of a drug can lead to a rebound hypertension and transient suboptimal control with the new agent, thus predisposing the patient to intermittent high BP fluctuation, which can augment the risk of developing CV events. Similarly, in heart failure patients, sudden discontinuation of AC is been shown to result in a deteriorating clinical status with a possible relative increase in mortality. In post-myocardial infarction patients with LVD, RAS blockade provides mortality benefit. Similarly, the use of ACE1 ARB reduces the risk of diabetic complications in patients with diabetes mellitus. Until more data became available, we feel that continuation of ACE ARB may or may not increase susceptibility to SARS-CoV-2 infection. but sudden discontinuation of AC ARB is more likely to result in decompensation of previously stable clinical state. Therefore, based on all this data, European Society of Cardiology and American College of Cardiology does not recommend the discontinuation of AC inhibitors or ARB therapy in patients with heart failure, hypertension, or myocardial infarction who are also suffering from SARS-CoV-2 infection. Moreover, ACE2, whose expression is enhanced with an AC inhibitor or ARB therapy, has the ability to suppress inflammation and has been suggested as a potential new therapy for inflammatory lung disease, cancer, diabetes, and hypertension. Given the fact that no current evidence that proves a direct causal relationship between the use of AC inhibitors, ARBs, and COVID-19 infectivity or mortality, and the fact that AC inhibitors, ARB, have many benefits in CV disease. Thank you.